Hello, my name is Dr. Benjamin Abella, and I'm the Clinical Research Director at the Center for Resuscitation Science at the University of Pennsylvania. This short lecture today is going to discuss the TTM trial, or Targeted Temperature Management Trial. This trial was presented at the American Heart Association Scientific Sessions this month, and it was also published in the New England Journal. This is the New England Journal publication that just appeared. There have been many questions from clinicians who are involved in the care of post-arrest patients, how to interpret this trial. And so we thought it would be useful to give you our thoughts and a little bit of commentary about the trial. This lecture is also loosely based on a lecture I gave at the American Heart Association in response to the trial. Now, before I go through the trial and what I think it means, I thought it would be important to lay out some guidelines. First of all, the purpose of this lecture is to provide some interpretation and commentary about the trial and hopefully offer some guidance to healthcare providers who treat patients after cardiac arrest. Important disclaimers to note. This slide set in no way reflects official positions or opinions of the American Heart Association or other guidelines organizations. In addition, the slide set really just represents the opinions of myself as a scholar in the field and in collaboration with other members of the faculty of the hypothermia and resuscitation training course that we run at Penn. And the slide set was crafted based on the best knowledge and evidence that we have currently. This field is evolving rapidly, as we know from the TTM trial, and the content therefore may not reflect the reality 6 months from now. So with those disclaimers in mind, a little bit of overview. Many of you viewing this today are very well aware of targeted temperature management after cardiac arrest. But the basic idea is that if you resuscitate someone from cardiac arrest, you lower their body temperature, you maintain them, and then rewarm them. So that is the basic schematic. And the current AHA recommendations are if you have a resuscitated patient who had an initial ventricular fibrillation rhythm, who is not waking up after cardiac arrest, they should be cooled for 12 to 24 hours to a target temperature of 32 to 34 degrees centigrade. That is what the guidelines recommended in 2010. Now, the TTM trial has thrown this into a bit of, not disarray, but has raised some speculation as to what is the best approach. Before I actually tell you my opinions, I thought it would be important to point out that I do have some conflicts of interest in this area. I've received funding from some sources, including some of the industries that provide cooling equipment. It's important for you to keep that in mind as we go through this. Now, post-arrest care is very important. As you all know, cardiac arrest is a leading cause of death in the United States, with a very high mortality rate. Among the patients who make it to hospital discharge, many of those survivors have neurologic injury. And the purpose of this targeted temperature management approach is to lessen both mortality and neurologic injury following cardiac arrest. You saw this. I'm going to show it to you one more time. The approach of TTM is to cool people down, and this lessens this neurologic injury through a variety of mechanisms that we don't completely understand, of course. Now, there were 2 trials that brought targeted temperature management into our current therapeutic decision-making process. These trials were the HACA trial, or hypothermia after cardiac arrest trial, that randomized patients to either no cooling whatsoever, no temperature management, versus a target temperature of 33 Celsius. And this trial showed a remarkable and statistically significant improvement in survival to hospital discharge when patients were cooled to 33. In a second trial published also in 2002 from Stefan Bernard and his colleagues, again, large survival improvements when patients were cooled to 33 versus no cooling whatsoever. Now, the current targeted temperature management, or TTM trial that just came out, makes a bit of confusion around this area because in their trial they randomized patients to targeted temperature management of either 36 or 33, and they found no difference in survival whatsoever between the 36 and 33 degree groups. So really the purpose of this slide set and this lecture today is to make sense of this. How can this be? How can these 3 different trials, all of post-arrest patients, have such radically different results? Well, like many trials, the devil is in the details. What I'm showing you here are the temperature curves from the 2 trials lined up next to each other. I've made the scales identical so that they can be directly compared. I've shown you here a bar at 38 degrees centigrade, so you can see, for perspective, some of this scale. And you can readily see that in the green line on the left, in the Nielsen trial, 36 degrees Celsius control meant that very few patients got pyrexic. Very few patients got above 38 or even close to 38 degrees Celsius. On the other hand, in the HACA trial, many patients did. If you look at the mean temperatures in the control arms, the 36 degrees Celsius arm, not really technically a control group, versus the control group in the HACA trial, the differences are apparent. The Nielsen study by design maintained people very carefully at 36 degrees centigrade, whereas in the HACA trial, there was no temperature control in the control arm, and indeed they reached a somewhat warmer temperature of 37.6. That's a 1.6 degree difference, which is quite large as far as mechanisms of injury goes. In the Bernard trial, we don't have their temperature curves published, but I can tell you, looking at their tables in their New England Journal paper, they also, in the control group, had 37.3 as the mean temperature. So a very, very big difference between the maintenance temperatures in these three trials. Now, what does that mean? The most important point I want you all to take from this lecture in the TTM trial is the TTM trial did not reassess whether targeted temperature management is a good idea or not. They did not test the same hypothesis as the HACA or Bernard trials. In fact, what they did is they controlled temperature in both arms of the trial. So 36 degrees, the control group, if you will, of the TTM trial, was still an active management of temperature. Very big difference between this and the prior trials. The other thing that I think is important to think about is the degrees of injury. We all have seen this clinically, that patients after cardiac arrest can either be severely neurologically injured and have severe post-cardiac arrest syndrome in the days following resuscitation, or they could have moderate injury or mild injury. Now, the issue here is that if patients are very sick after resuscitation, we know, we see this, you've seen this, that despite targeted temperature management or not, they have a poor outcome. And we know this often as we're initiating cooling. In a similar sort of fashion, patients with very mild injury tend to do well. And we often wonder if they even needed targeted temperature management at all. These are often patients who are younger, healthier, with a short downtime and good bystander CPR. Now, it's important to note in the TTM trial, the majority of patients received bystander CPR, a very impressive number, in fact, 74% of patients received bystander CPR. Now, think about that in your setting. Do 74% of patients receive bystander CPR who come to your hospital for care? We certainly don't see that at our hospital. So that leaves us with this third ill-defined group of moderate injury, perhaps people who didn't get as much CPR or had longer downtimes or just had more baseline injury or other factors we can't even measure. I worry about those patients. I worry that those patients might need 33 degrees Celsius. That deeper cooling may benefit these patients. Now, you should know this is an untested hypothesis in the clinical literature, and we do not currently know how to identify moderately injured patients after resuscitation. But I fear that if all patients get 36, we may not be offering benefit to this moderate category. So I want to now walk you through what our approach, after much discussion, is going to be for targeted temperature management in light of this new trial. So a little bit of the rationale. Given that targeted temperature management trial was neutral, meaning there was no difference in either benefit or harm from the trial, so there's no difference in adverse effects between the 33 and 36 degree groups. And in addition, given that cooling to 33, the basis of the current AHA guidelines, was based on both extensive laboratory evidence and 2 randomized controlled trials that have very positive results, and given that we cannot tell who will have significant post-arrest injury based on our current technology or even the clinical factors. As you all know, downtime and witnessed arrest and these sorts of things often do not correlate with the degree of post-arrest injury. And finally, we all know that you have one chance to modify neurologic injury following arrest. Oftentimes, if you have not cooled them initially, the injury is baked in and the patient may have a neurologic injury that they'll have to live with. So given that we have one chance to improve outcome, we have therefore concluded the following. And this is our approximate recommendation at this time. And as I say, this may change, but this is what we're going to start doing at our hospital. We believe it's reasonable to not change current practice patterns based on the TTM trial, but rather to continue to treat comatose post-arrest patients with a goal temperature of 33 degrees Celsius. However, In light of this new trial, we think there is evidence that a more flexible approach may be possible. For example, if a patient is not tolerating 33 degrees centigrade, or you as a clinician feel that there's too much risk, you're uncomfortable cooling to 33 for other clinical factors, instability, marked bradycardia, bleeding, it is certainly reasonable and acceptable in light of the TTM trial to have a higher temperature goal up to 36 degrees Celsius. So we have more flexibility in our treatment options for patients following cardiac arrest. But given that this was a null trial, both with benefit and adversity, we do not feel a need to change our current approach at this time. The other, of course, important thing to reiterate, all comatose post-arrest patients should at least receive TTM with a maximum temperature goal of 36. What do I mean by this? Normothermia is no longer acceptable. If you have a patient following arrest and you do not feel they're appropriate for cooling to 33, at the very least they should be cooled or maintained at 36 degrees Celsius. That is the fundamental lesson of the TTM. Not that we shouldn't do targeted temperature management, but that we need to at least manage their temperature at 36 and aggressively avoid fever. Then finally, the other aspect of the TTM trial that's so important is that all post-arrest patients should receive aggressive best practice care, including avoidance of fever for several days following rewarming, and the avoidance of withdrawal of care for at least 3 days following arrest. And this is in the current guidelines, and this was an aspect of the TTM trial, and I think a very, very important component of any post-arrest protocol, whether or not you cool to 33 or to 36. Of course, really fundamentally, what the TTM trial tells us is there's a great need for additional research in this area. We need to understand what is the appropriate dose of TTM. Should we cool to 33 or 36 for all patients or for some patients? What should the appropriate duration of care be? And so forth. Many questions remain to be answered. Now, we run at the University of Pennsylvania a resource page on this. The link shown here will take you to a page where we have other information about TTM and a list of hospitals in the United States that have said that they offer TTM therapy and other resources that you might find helpful. I now also want to introduce to you Marion Leary, one of our lead nurse coordinators, for some final closing thoughts.
Hello, I'm Marion Leary. I'm the Nursing Co-Director of the Hypothermia and Resuscitation Training Institute at Penn and the Clinical Director of Research with the Center. If you would like to learn more about this topic and if you would like to continue on the discussion, please check us out at our website. On our website, we have many resources. You can email us directly, and you can also engage with other clinicians from around the world on our Google Groups. The statement that Dr. Abella made today was a consensus of a group of our faculty from the Hypothermia and Resuscitation Training course, Dr. Gajewski, Nurse Coordinator Gail Delphin, and others. We would like to receive your information and your questions on this topic and other topics, so please feel free to email us as you need.